Prachin T.
Yes,
Yes.
sir.
Good, good. So can you describe a clinical scenario where you will make a clinical diagnosis of choledochal cyst?
Actually, choledochal cyst is actually by triad of having pain, jaundice, and abdominal mass.
So, sir, we have to respond to his Prachin has given his answer. So do we have to kind of...
Yeah, we can. So you describe the clinical presentation. These are the symptoms or signs, because what I asked that describe a clinical scenario. So I expect you to say what age, what gender, what is the clinical picture, what are the findings, how frequently you see all these three.
Actually, it's very rare, but
let us split it. In an adult,
okay.
How many times have you made a clinical diagnosis of choledochal cyst?
It's very rare. Actually, I didn't make anyone, sir.
In an adult, one that this triad, pain, jaundice, and lump is very, very uncommon, isn't it? The commonest presentation in an adult in patients in whom you finally diagnose choledochal cyst is jaundice, cholangitis, and pain. Lump is very unusual, very rarely present. So in that clinical presentation, what I'm trying to say, the commonest clinical diagnosis will be CBD stones. It is only on imaging that you find that it is not simple CBD stones, it is a choledochal cyst. But is there a situation where you can make a clinical diagnosis of choledochal cyst? Age?
Maybe a young adult.
Yeah, so if a child or a young adolescent presents with the same clinical picture, because stone disease is not common at that age, then maybe your first clinical diagnosis could be choledochal cyst. Richa, please take on.
Yeah, so Prachin, again to reiterate, your first response was that the typical presentation is pain, jaundice, and lump. So although this is theoretically described as a classical triad, but clinically, this classical triad is seen only in 10% across all age groups, whether it is an adult or a child. Then again, as Dr. Kapoor said, in adults, most of the times the diagnosis is made when a patient presents with either recurrent biliary colic or jaundice or cholangitis, and you do an imaging and then you detect a choledochal cyst. However, in a child who presents with biliary colic or jaundice, our first diagnosis is always a choledochal cyst. We must remember that in a child, a choledochal cyst is much, much, much more common as compared to CBD obstruction because of a stone disease. And a lot of times the differentiation is difficult, and therefore now we will come to the features as to how you can differentiate a choledochal malformation from biliary dilatation because of stone disease.
So why I raise this? Because many a time the students in the exam, especially when they know the diagnosis, they make a diagnosis of choledochal cyst in a patient, in an adult who comes with pain, jaundice, and recurrent cholangitis, but that is not correct. Your first clinical diagnosis should be CBD stone. And as I said, when you do the imaging, then you find that it is choledochal cyst. Okay? Yeah. So suppose you have an adult who presents with pain, jaundice, and recurrent cholangitis, and clinical examination just reveals jaundice, or at that time there may not be jaundice because there is intermittent jaundice. It is not that all the time patient has jaundice. What findings on imaging or on investigations would make you suspect that it could be a choledochal cyst? Prachin.
So on ultrasound, there will be dilated CBD, maybe fusiform dilatation, or according to the type of the choledochal cyst, there may be fusiform dilatation or just taken outgrowth. or they may be intrahepatic or extrahepatic biliary radical dilatation in imaging
So
wise.
same findings would be there in a CBD stone also.
But there is a fusiform dilatation, and it will be a more symmetrical dilatation.
CBD stone, there is no symmetrical dilatation. What is the key word which you have to mention when you are talking of biliary dilatation? What is the key word? The key word is disproportionate dilatation. See, whenever the dilatation is because of an obstruction, of which the commonest cause is CBD stone, or it could be malignant obstruction, then the dilatation is uniform, starting from extrahepatic, going on to intrahepatic, first order, second order, third order, peripheral IHBR. So it is a proportionate symmetrical dilatation. On the other hand, in choledochal cyst, especially the commonest variety, which is the type 1, there is disproportionate dilatation of the extrahepatic bile duct. So you see a hugely dilated extrahepatic bile duct, and the intrahepatic ducts are either normal or they are not dilated to the same extent. So disproportionate dilatation is the key feature of dilatation in choledochal cyst. Fusiform dilatation is one type of choledochal cyst. Not all types of choledochal cyst will have fusiform dilatation. Yeah, Richa, please.
So, sir, actually, because this is very often a clinical and a radiological dilemma, and we were discussing about this yesterday telephonically, I took out some slides. Should I share them?
Yes, please. Please go ahead.
The cholangiograms, so that, they get an idea of what we mean by saying disproportionate central dilatation. But, sir, you will have to give me permission.
We are asking Avinash because Avinash handles the technical part, his team. So we'll just ask. In the meantime, we can continue. So, Prachin, what I was saying, if you have obstructive dilatation, which is stone, stricture, malignancy, versus in choledochal cyst, it is a functional obstruction. There is no mechanical obstruction, and there is disproportion. So if you have a type 4 choledochal cyst, then you will have both intra and extra hepatic ducts dilated. But the difference is that when there is a dilatation because of CBD stone, as I said, symmetrical dilatation of this. Whereas in type 4 choledochal cyst, you will have areas of narrowing, stricture, and then dilatation, stricture, and then dilatation, the chain of lakes appearance, like what you see in chronic pancreatitis also. So there is a difference in the pattern of dilatation in CBD stone versus choledochal cyst.
And we can also add to it, sir, that now with the very good imaging, like a good MRCP, if you can visualize a long common channel, that also really helps you to the diagnosis in favor of a congenital choledochal malformation. And thirdly, if it is gallstone disease with a calculus which has slipped down into the CBD and hence CBD dilatation, the gallbladder would be packed with calculi. The gallbladder would be thick-walled and often contracted. Whereas, I wanted to show a few cholangiograms. In choledochal malformation, the gallbladder either has no calculi or has few calculi, but usually the gallbladder is very well distended. It's a well-distended gallbladder. So those are the other two features which can help in differentiating. Like consciously look for a common channel and look for gallstones also, and the size of the gallbladder.
Next student, please be ready. Prachin, can you tell us what is this long common channel? What Dr. Richa is referring to?
It's a congenital anomaly in which the common after this CBD, after joining the pancreatic, there will be long common channel will longer.
How long?
It is more than, I'm not sure, so it's more than 2 centimeters.
I
think there are different definitions, but the one I remember is about 15 mm. Richa, am I correct?
Yeah, so if we have to go by the length, then in adults it is said more than 15 millimeter. In children, of course, the length varies with the age. For infants, even more than 2 millimeters is supposed to be long. By the time a child becomes an adolescent of 12 to 15 years, we say more than 10 millimeter. But essentially, Prachin, the concept is that the PB junction lies outside the duodenum. So nowadays with endoscopic ultrasound, you can actually pick up a long common channel, because if the PB junction is located outside the duodenal wall on an endoscopic ultrasound, then you can say that this is a long common channel. And of course, ERCP is the ultimate gold standard, but ERCP is invasive. And you would not like to do it only for diagnosing a long common channel. You usually would like to do it only when you want to plan therapeutic intervention at the same time.
A good MR reconstruction which shows the soft tissue so well can also show the duodenal wall and then show whether the junction is outside. Richa, now you are the co-host. Please show your slides. You can share your slides now. So while Dr. Richa's slides are coming up, sometimes it becomes very difficult. Then the other way is that you remove the CBD stone. So if there is a stone, you don't know whether it is a choledochal cyst with stone or whether it is a stone causing CBD dilatation. You remove the stone endoscopically and see what happens to the CBD. If the dilatation is because of the CBD stone, once you remove the stone, the dilatation over a period of time reduces and the CBD should come back to normal. On the other hand, if it is a choledochal cyst, even after removal of stone, the dilatation persists because it is not the stone which was causing the dilatation.
That is a very important point, sir. So is my slide visible now?
Not yet.
No.
I think first you open your presentation and then share.
My presentation is open, but... Okay, sir, you can continue with the discussion. I will see you.
Yeah.
Just maybe one touch cutting section.
Have you clicked on that share screen option at the bottom? There is a green. Just click on your screen somewhere. At the bottom, you will see the share screen arrow.
I have clicked on share screen. So you carry on with the discussion. I have clicked on share screen, but
anything in the LFT, Prachin?
Yes, sir. Yes, sir.
LFT, anything in the LFT which can suggest that it could be a choledochal cyst? Richa, now we can see your slides. Make it a slideshow.
Serum alkaline phosphatase will be raised, sir.
If it is raised, it will be raised in CBD stone also. It is the other way. If you have a CBD dilated, but the LFT is normal, then it should raise a suspicion of a choledochal cyst. Because if the dilatation is because of an obstruction, then obviously the ALK phos and GGT will be raised. But in choledochal cyst, because it is a functional obstruction, there is dilatation, but LFT may be normal. Not that every patient it is normal, but if that is the situation, then your suspicion of CBD choledochal cyst becomes even stronger.
पंकज मैं बिजी हूँ बेटा. हाँ कोई बात नहीं मैं बिजी हूँ. Sorry. So is the slide?
हाँ, I think Richa, एक बार stop share करके. Stop sharing once because we can see multiple windows actually.
Okay.
And now if your presentation is open, share screen and click on the presentation.
So you continue with the discussion. Maybe yes, I will have to kind of...
No, that's okay. So let the next student come in. Praveen, what is the investigation of choice? Suppose on ultrasound, you suspect that there is a choledochal cyst. There is some dilatation. It is disproportionate. What is the investigation of choice? Praveen? Sudeep?
Yeah. Sir, I will do the MRCP, sir, for next line of investigation. I am suspecting choledochal cyst because I want to know the is there any ABPJ or is there any other filling defects which can be like a cholecystolithiasis? Is there or not?
Cholecysto or choledochocysto?
Choledochal yes.
So what are the important things which you look for? How do you confirm that it is a choledochal cyst on MRCP? What findings?
So there will be a pattern of dilatation that you mentioned in the discussion, like it can be a cystic or it can be a saccular or it can be a fusiform pattern of dilatation, and other things like there is actually IHBRD, how much of intrahepatic dilatation is there, and is there also focal Caroli's or Caroli associated diseases is there or not. And if it's an adult patient, I would like to see any kind of mass is there in a gallbladder or in a hilum associated. Sometimes cholangiocarcinomas are associated with the any suspicious like a papillary pattern of any disease like. So I will try to go through all this.
Yeah, so a better way to answer it would be that first I would look at the MRCP to confirm the diagnosis of choledochal cyst, which will be confirmed based on, as we discussed earlier, a disproportionate dilatation, mainly of the extrahepatic biliary system, with no proportionate dilatation of the intrahepatic ducts, and certainly very little or no peripheral intrahepatic biliary radical dilatation, which is the commonest type, the type 1. In type 4, you would see, in type 4A, you would see dilatation of extrahepatic as well as intrahepatic ducts. But in the intrahepatic ducts, usually you see strictures and dilatation, the chain of lakes appearance. Now, you must remember that even in type 1 choledochal cyst, fusiform cyst, the dilatation of the extrahepatic system, that is the CBD and CHD, may extend into the right and left main hepatic ducts, but that is a continuing dilatation. So that doesn't make it type 4. In type 4, you have to have an area of narrowing and then dilatation. So this continuing dilatation, once you treat the choledochal cyst and you follow the patient up with some kind of imaging, you will see that it will disappear. So this is one difference between type 1 and type 4A choledochal cyst. And then, of course, you have the other rarer forms, because type 1 and type 4A are the commonest forms of or types of choledochal cyst. Others are rare. So they need not come in clinical discussion. Of course, if the MR findings suggest that, then you make a diagnosis. Now, once you have made a diagnosis of choledochal cyst on MR, two important things which you have to look for. One is where the pancreatic duct is joining. Is it joining the cyst, the dilated part, or is it joining below the cyst, below the cone of the cyst, where you have the normal undilated terminal part of the CBD? That is important from surgical point of view when we come to surgery, as to whether you can completely excise the lower cone of the choledochal cyst without risk of causing injury to the pancreatic duct, or whether you have to leave a part of the cone because the pancreatic duct is joining in that part. And second, you have to look at the upper end. What when Dr. Richa was with us in SGPGI, have reported that anomalies of the biliary system, especially the right ducts, segmental, sectoral, or even the right main duct, they are there even in normal population, but they are more common in patients with choledochal cyst. So if there is a right apparent duct which is joining the choledochal cyst, and you don't kind of look for it, you don't recognize it, and you completely excise the choledochal cyst, then you will cause an injury to that duct. So you have to look for these anomalous ducts. And as we will discuss, there is a technique by which you can prevent an injury to these ducts. Yeah. Richa, now you can share.
So I'll try.
And then, yes, as you said, that in an adult, definitely you look for a suspicious mass lesion. And the next point which I was going to ask is that if you have a suspected mass lesion, then many surgeons would be more comfortable with a CT rather than an MRI. So that is one situation where in a choledochal cyst, you may ask for a CT scan also.
So is my screen visible now?
But we can see this thing.
So
we are
now
not on the slideshow. Just
okay,
convert it
so
into
slideshow and then set up slideshow. Is it, sir? Because the way I used to open was a little. So should I click on setup slideshow?
You can. No,
Ma'am, you have to open these slides in the background. Make
Yeah.
in the PPT mode in the background. Then share this. Then share this.
No, that I have already done, beta. That I have already done. So,
ma'am, once stop sharing again. Ma'am, stop sharing again and go your presentation. Make it in the PPT mode. Then this PPT mode, you have to share this PPT mode slide. From beginning and ये भी बता दे सर from beginning पे click करके देखिए सर
एक बार from beginning पे click करो left upper corner में
ऐसा ये है यहाँ पे ना slide show. So set up slide show presented by the speaker.
Not set up. Click on from beginning. I think as Anand is suggesting, एक बार आप stop share कर दो. Just stop sharing. Now on your laptop, you open your presentation.
So it's opened.
It is open. Make it a slideshow. Or just open the first slide in the normal PowerPoint mode. Don't go to the slideshow. Just open the first slide. Or the slide which you want to show anyone.
So this problem is happening for the first time. I do not know why. So
आपके multiple windows तो नहीं खुले हुए हैं?
नहीं, multiple windows तो नहीं खुले हैं sir. But there is something which is going amiss.
या फिर bottom में जो slide show का एक icon आता है उसमें.
I'm not being able to kind of.
So I think there is some problem in your PowerPoint software.
Sir, can you see my multiple slides?
हाँ, multiple slides तो दिख रहे हैं.
So can I speak on the? Can I show this?
हाँ, ठीक है. That's okay.
So is my cursor visible on this slide?
Yes.
So the point that Dr. Kapoor was trying to make was Pratik and Hanuman that, this was an 11-year-old girl and she presented with biliary colic. And if you look at this cholangiogram, there is a calculus impacted at the lower end and there is a meniscus sign here. And but she did not have any calculi in the gallbladder and we could not visualize the long common channel on the MRCP. So this was a very equivocal situation for us as to whether we were dealing with a CBD calculi disease or whether we were dealing with a fusiform congenital choledochal malformation. So how do we approach this?
Richa, there is a suggestion from Praveen. Try the F5 button at the F5. Maybe it will work.
So वो भी नहीं काम कर रहा है ये.
I think हाँ आपके सॉफ्टवेयर का कुछ.
But if the cholangiograms are visible, then I can.
Yes, that's okay.
Yeah. Okay. So now these are two.
Actually आप थोड़ा enlarge कर सकते हो इसको नीचे right lower corner में ना make it.
So actually all those functions are there, but I do not know why I'm not being able to do it today.
हाँ तो कुछ problem है PPT में कुछ problem. ठीक है.
So now if you can appreciate these two cholangiograms, I'm sorry they are so tiny, but this is what sir meant by saying disproportionate central dilatation or disproportionate dilatation of the extrahepatic biliary system with an abrupt peripheral pruning. So there is disproportionate dilatation of the CBD and the CHD, but the upper tracts are not dilated. Or again here, if you look at it, there is disproportionate dilatation of the CBD, the CHD, the left duct, the right duct, but the second order branches are abruptly pruned. On the other hand, these two cholangiograms, these were given to me by Dr. Kapoor. This is calculus with uniform upstream dilatation with gradual tapering. So, like, am I audible and are my slides visible?
Yes. Okay.
Now, here you can appreciate the common channel so nicely. These are all pediatric choledochal cysts. So this is a long common channel. it is dilated, there is sludge in the common channel. So, if you remember the Kimura's classification, you can call it a BP type of a common channel. Again, a long common channel. Again, a long common channel. So if you can see a long common channel, it substantiates your diagnosis of congenital choledochal malformation. Then the point about the gallbladder, you look at the gallbladder in each of these cholangiograms. The gallbladder is so hugely dilated and actually redundant. Even the cystic duct is very dilated and redundant. Whereas in calculus disease, it will often be, the gallbladder will often be packed with calculi. It will be thick-walled and often shrunken. So in this particular child, which, I started with, we had a huge dilemma. And as sir was saying, we decided that we will do an endoscopic clearance of the stone and we will just keep this child under follow-up as to how the CVD dilatation behaves, whether she has subsequent biliary or pancreatic symptoms or not, and how do the biliary enzymes behave, and accordingly take a decision. With time, the disease declares itself. So that is it. And other thing, point which Dr. Kapoor was trying to explain is that very often radiologists overdiagnose type 4 choledochal cyst. For instance, this kind of a choledochal cyst, a radiologist might report as type 4. But from the perspective of management, this is not a type 4 choledochal cyst. It is a type 1 choledochal cyst with contiguous fusiform upstream dilatation. So we have to differentiate this kind of a type 1 choledochal cyst with a contiguous upstream fusiform dilatation with a true type 4 cyst wherein there is disproportionate upstream dilatation with an area of stenosis here. Why? Because here you can transect the cyst here and make an anastomosis here, after which all this upstream dilatation will subside. This is the post-op MRCP of this child. But here, you have to carry the anastomosis proximal onto the left duct. So this was the point which Dr. Kapoor was trying to make. It is very important to differentiate between contiguous upstream fusiform dilatation versus the true type 4A choledochal cyst, wherein there is disproportionate upstream dilatation with an area of stenosis, wherein your anastomosis has to go proximal to these sites of stenosis.
So I think you can show that secular variety also, the last image in this.
This one, sir?
Yeah.
Yeah. So this one also, this actually, again, so here again, you can see that this disproportionate upstream dilatation with an area of stenosis here. This is another of our patients, wherein at the time of surgery at the hilum, we found this septal stenosis. Another cholangiogram where you can see these area of stenosis with disproportionate upstream dilatation. This is a picture of intraoperative choledocoscopy, wherein there was a septum here, which was causing this stenosis. And this is another child where there was disproportionate upstream dilatation with an area of stenosis at the confluence. And this we could detect, and there was a web. There was a web at the confluence, which we had to excise.
Students, if you notice the second image, second slide in the first row, you see the fusiform dilatation of extrahepatic bile duct, which is extending into right and left. And if you see the last image, this is the secular type, where there is a huge sac of the extrahepatic bile duct. Okay.
And sir, you were talking about variant anatomy. So sir has made a very important point that the only way to prevent injury to a variant anatomy is to consciously look for it on preoperative imaging, and then of course intraoperatively. So that intraoperative step we will come to later. But on MRCP, I mean, MRCP gives you that advantage that you can rotate the images through 360 degree. So you should make a conscious effort to identify each and every segmental and sectoral ducts. And if you're not being able to identify a particular sectoral duct at the confluence, then that is one subtle sign to tell you that maybe the sectoral duct or the segmental duct is opening somewhere lower down, either in the CHD or into the cyst or at the junction of the CHD with the cystic duct. So would you agree with me?
Good cholangiogram, and then we will come to how you prevent an injury intraoperatively.
Yes, yes, sir.
Okay, so who is the next student? Who? Hanumant? Please come in. Hanumant Naik. Who else is there? Okay, and maybe Sudeep, you can continue. Sudeep?
Yes, sir.
Yeah, okay. So once you have diagnosed, let's say we have diagnosed the most common variety, which is type 1, isn't it?
Yes, sir.
Type 1 fusiform choledochal cyst. What is the management?
So I would like to, sir, actually, first I diagnosed and then I would like to preoperatively assess the fitness of the surgery and like to do
What
a...
was the question? What was the question I asked? I said we have diagnosed type 1A, type 1 fusiform choledochal cyst. What is the management? So where is the question of I will diagnose? I have already given you the
So
diagnosis.
choledochal cyst excision with a bilioenteric bypass.
That's what you should say, that the treatment of choice for a choledochal cyst is surgical in the form of excision with a Roux-en-Y hepaticojejunostomy.
Yes,
That is
Yeah.
the correct answer.
And don't use the term bilioenteric bypass, Sudeep.
Bypass means that you are not treating the primary pathology. You are leaving it as it is and doing a biliary entry anastomosis, which is not the recommended treatment. So the answer is excision of the choledochal cyst. In type 1A, you can completely excise it, and a Roux-en-Y hepaticojejunostomy. Can you tell me a situation where, although you have a choledochal cyst, but you would say, I would not like to operate, or I may not operate?
Very old age person.
And
And so not any symptoms and incidentally detected.
yeah, so
That
and
those patients I...
incidentally found choledochal cyst, say on a routine ultrasound done for dyspepsia or for some other indication, where you find a choledochal cyst and patient is old. Now, there is no cutoff for old. It depends on age, comorbidity, and other things. Then one may not operate, although it's a very subjective decision. Some people may take a more aggressive approach and say that if today the patient is fit, why not operate today rather than operate 5 or 10 years later when the patient will have more comorbidities or will be less fit for anesthesia. But that probably is the only situation where you would not. Otherwise, in a child, in an adult, in a middle-aged person who is otherwise fit for surgery, even an asymptomatic choledochal cyst needs to be treated. Why? Why should we treat an asymptomatic choledochal cyst?
Because there is actually, if you are not resecting the choledochal cyst, there is actually, the literature says that around 30% chance of untreated choledochal cyst can have a malignancy. So that is one of the pre-malignant factor, choledochal cyst with ABPJ, like abnormal biliopancreatic junctions. So that's why
Again,
it
we
should be...
don't call it resection. We call it excision. Resection is the term used for
Yes, sir.
usually masses or tumors. So it is excision of choledochal cyst. It is not resection. Second, I don't know. Can you give the reference for this 30% incidence of malignancy? I don't know whether there is a definite figure available. So two reasons you should say. One is that even if it is asymptomatic today, what is more common, malignancy or symptoms?
Asymptomatic today, so it can be symptoms also can occur in the form of biliary colic, sometimes stones can form.
The
And
usual symptoms. So
yes,
it can become symptomatic. And second is the risk of malignancy. So can you tell us a little bit more about risk of malignancy in choledochal cyst?
Sir, can I give the
Yes,
figures about
yes.
malignancy from the Japanese choledochal cyst registry? So across all age groups, they have said 16% of choledochal cyst, their first presentation would be like a malignancy. That is the Japanese choledochal cyst registry. Of course, it keeps on increasing as the age increases. So instead of using the figure of 30%, Sudeep, if you really want to quote a figure, then say as per Japanese choledochal cyst registry, 16% of all cases present may have malignancy in a choledochal cyst. If you want to quote a figure.
okay, ma'am, thank.
Yeah.
So the malignancy most commonly we see in a will be a GB carcinoma, sir, and followed by cholangio, can be a distal or can be a high proximal cholangio, hilar cholangiocarcinoma. Also, there can be other like intrahepatic cholangiocarcinoma also can be seen. So three variants of carcinoma we can see in a patient with a choledochal cyst with a ABPJ. Um, and these patients are actually, if early detected, can be these are the actually I can't tell more than this
Yes,
carcinoma variants.
a small correction that
Yes,
the
sir.
commonest malignancy in choledochal cyst is a cholangiocarcinoma. The gallbladder cancer is when you have an anomalous pancreaticobiliary ductal junction, but no cystic dilatation of choledochal cyst. In that subgroup,
Okay.
gallbladder cancer risk is very high. And in fact, in Japan, that is an indication for preventive cholecystectomy. The risk is so high that they advocate a preventive cholecystectomy. So anomalous pancreaticobiliary ductal junction detected on MRCP or US done for whatever reason, and the CBD is not dilated, so there is no choledochal cyst, then for some reason, the risk of gallbladder cancer is very high. Otherwise, in a choledochal cyst, the commonest malignancy is the cholangiocarcinoma. Where does the malignancy occur?
Uh, so actually, in a choledochal cyst, it can be like a what is that? Field actually field canceration can happen, sir. So varying from the distal most part of the CBD to the hilum, there can be. So very high likely when a multifocal we can see with the patients of choledochal cyst, the keep the cancer is arising.
So there are two hypotheses. One is the reflux of pancreatic juice into the biliary duct, which causes changes in the biliary epithelium. And that is taken care of when you disconnect the pancreatic duct from the cyst when you excise it. But second hypothesis is that the entire biliary tree, including the non-dilated part, including the intrahepatic part, which is normal, not dilated, is carcinogenic. So obviously that risk you cannot decrease by excising the extrahepatic ductal system. Richa, anything you want to add?
And so there can be a periampullary carcinoma
Yes,
also.
yes. The lower end cholangiocarcinoma, which is a periampullary carcinoma. Okay,
And
so
then we can talk about after choledochal cyst, what are the chances that there can be a malignancy and what patients are at risk after excision?
Ma'am, in after excision, the distal stump sometimes can be the if we are actually leaving so much of the distal stump, there can be also focus of carcinogenic, ma'am, like carcinogenesis in those distal stump. So they can mimic as a head of CA pancreas sometimes in a post choledochal cyst excised patients. And also, if there is actually associated focal carolis or sometimes in those patients, there also you can see a ma'am intrahepatic cholangiocarcinoma, the post choledochal cyst excision patients. Two possibilities.
Yeah, so essentially, what you need to understand, Sudeep, is that since we are talking about choledochal cyst being a pre-malignant condition, and that is why we advise surgery even in an asymptomatic case. So a good choledochal cyst excision with the Roux-en-Y bilioenteric anastomosis definitely decreases the chances of malignancy. The reported incidence of malignancy after choledochal cyst excision has been less than 1%. And all these cases who have had malignancy after choledochal cyst excision were patients who were operated beyond childhood. And that is why there is an emphasis on early surgery. Because essentially the pathogenesis of malignancy is ongoing pancreaticobiliary reflux and stasis, which leads to chronic inflammation, which then leads to metaplasia, dysplasia, carcinoma, that kind of a sequence. So the earlier in life you interrupt that sequence or you interrupt the pancreaticobiliary reflux, the lesser are the chances that the patient will develop malignancy later in life. So therefore, operate early and operate even in asymptomatic cases. Now, what are the cases who are at risk of malignancy post-surgery? These are the patients who have been operated late. These are the patients who have a long common channel. These are the patients who have a type 4 anatomy, wherein there is a residual intrahepatic cystic dilatation, and who may continue to have cholangitis even post-surgery. So these are the kind of patients who are more at risk. So malignancy can occur in the residual intrahepatic cystic dilatation part, and it can occur at the lower end also.
Next student, Ravi Shankar. Can you please come in? Dr. Ravi Shankar Malviya, yeah. So tell us about something about the surgical technique. Tell us important steps while treating a choledochal cyst. Ravi Shankar? Who wants to come in? Praveen, you want to join again? Okay, Sudeep, you continue then. Yeah.
So the operative approach will be my sir. Actually, I'll take one subcostal incision. Sometimes in adult we have to little bit extend up to the upper midline. In the child age group, we can do with another only the subcostal like a coccus incision is only enough. So after taking the
is that the only way that you can operate on a choledochal cyst? There are no other options.
laparoscopy also is an open choledochal cyst excision, and
today, whenever you are describing an operative procedure, you should start by saying that there is an option of open and laparoscopic, and I would do open.
Okay, sir.
Whatever you want to say. Okay, carry on.
And so I will. So once I inspected the abdomen, after inspecting the whole abdomen, and I will try to.
What are you inspecting the whole abdomen for in a choledochal cyst?
Actually, if it is like a long-standing, sometimes. So in the general exploration, we do the exploration and we see the levers, how the steatotic or it is a nodular, and if there is any cirrhotic part like any collaterals or
can say that if there is a long-standing history of recurrent episodes of cholangitis, the patient may have secondary biliary cirrhosis. So I would like to look at the liver. If the patient is elderly, if there was some suspicion of malignancy on imaging, then I would like to look for any evidence of dissemination of the malignancy, because that would completely change your management. So at this stage, whenever you make a statement, we don't want you to make a statement like an MBBS student, a general statement. We want you to say what you want to do and why you want to do it, specific. Yes.
Yes, sir. Then once inspection is done, then I'll start with this cholecystectomy with antegrade approach, sir, and followed by I will do the cauterization also, sir, for the and
why
and I will try.
Why cauterization? Why do you want to cauterize?
Not fully, sir, like any kind of like a CA pancreas or periampullary, but
why at all? Why you want to embolize the duodenum? What is the rationale? What is the reason? The reason is that you want to go down into the head of the pancreas to remove that cone, the lower cone. And
yes,
that is where bleeding can occur. So you want the pancreas in your hand. You want to be holding the pancreas. There are two procedures, maybe more, where you want the pancreas in your hand. One is which is the procedure where you want
phrase.
Very important. You want the pancreas in your hand. And second is this. Any procedure for that matter on the head of the pancreas where you are dissecting into the pancreas. You want the pancreas in your hand because that is the best way to temporarily control the bleeding before you can do something else. Yes.
And followed by, I will try, then after cauterization, I will start the hepatoduodenal ligament dissection. I will try to see the hepatic arterial course anatomy, like a course where it is like sometimes we don't do a CT actually, most of the time preoperatively when we are operating the choledochal cyst. So it's very high chance when sometimes actually hepatic artery courses in front anterior to the bile duct. So we may injure the right hepatic artery. So very carefully we have to dissect it away from the choledochal cyst. And many of times we see that there is a lot of inflammation around the choledochal cyst. There are a lot of neovascularization also there.
Any other artery? Any other
uh,
artery?
or also replaced hepatic, we have to also check. So
What?
right hepatic,
What
replaced
is
right hepatic.
replaced? What is replaced?
So is it actually it is a when the right hepatic artery arises from the superior mesenteric, it traverses in the posterolateral aspect of the hepatoduodenal ligament and mostly posterior to the common bile duct, posterolateral. So
What is replaced? What do you mean by replaced?
replaced means this is the only right hepatic artery which is supplying
Only
the
a replaced
hepatic.
right hepatic artery is at risk. What is the other term? What is the other variant? One is replaced, other is
Another accessory, sir. Both.
accessory cannot be injured.
Yeah, can be, sir.
Both can be. So
So both can be, sir.
what are they together called? What is the term which includes both accessory and replaced? So the common term is an aberrant right hepatic artery. Apparent means that it is arising from superior mesenteric. It is running on the right posterior. You said posterolateral. Posterolateral, agreed that it is right, but you should be specific on the right posterolateral surface of the common bile duct. Now, aberrant right hepatic artery can be either accessory, which means that normal also is there and this also is there, or it can be replaced. So both can be injured. So you should not say replace. You should say an aberrant right hepatic artery I will look for. Okay.
Then after that, then I will try to dissect whole the common choledochal cyst, both circumferential dissections value to start and mobilizing the choledochal
Where
cyst.
do you start dissecting? More at the upper end or more at the lower end?
Uh,
Hepatoduodenal ligament at the upper end or at the lower end? Where do you start dissecting?
so I will
And
start at the lower end, sir, because upper end we may sometimes land up in during the vessel like a right hepatic very
any other reason?
relation. And
what is the relationship of the CBD to the portal vein or hepatic artery, proper hepatic artery at the upper end of the or upper part of the hepatoduodenal ligament and in the lower part of the?
so CBD will be a most anterior, sir, in the
Anterior
in
at
the
both
upper part,
places.
both
What is the
places, sir.
difference?
Uh, artery sometimes lies like a right of the CBD in the lower part, sir.
So in the
Right,
lower part of the hepatoduodenal ligament,
ligament.
the three structures tend to separate out a little bit.
Separate, yes, sir.
There is more space there, and that
Space
is
in the
why
section.
many surgeons feel more comfortable starting the dissection there rather than at the upper end.
Upper end, sir.
What
So
problems do you anticipate when you are doing this dissection around the CBD or the cyst?
problems I encountered like bleeding, sir. First,
Where? Bleeding from where?
bleeding. Those sometimes we find some vessels around actually traversing into the choledochal cyst from the hepatoduodenal ligaments. So those need to be tackled like properly. Hemostasis has to be achieved while dissecting around both the. Second problem I anticipate that is due to repeated inflammation, there can be also portal vein can be very adhered to the posterior aspect of.
Very important. So patients who have had recurrent episodes of cholangitis,
Instrumentation also.
especially if the patient has required endoscopic stenting for control of that cholangitis, these are the patients who will have a lot of. So these are the terms you should use when you answer these questions.
Yes, sir.
They will have a lot of pericholedochal cyst inflammation, inflammatory fibrosis. the planes between the posterior wall of the cyst and the anterior wall of the portal vein will be obliterated. When I'm trying to dissect, my instrument may inadvertently cause an injury to the portal vein. Because when the planes are obliterated, when you try to forcefully dissect, what structure gives way? The thinner structure gives way. So inflamed choledochal cyst wall is thick. That is not going to injure. The portal vein wall is thinner. That is what is going to get injured. So you have to be very, very careful in doing this dissection in patients in whom this plane is not clear. And it's a very dangerous, fatal complication, because once the choledochal cyst is sitting in front of the portal vein and the portal vein gets injured, there is no way that you can control that bleeding.
Then after mobilizing the whole choledochal cyst, I'll try to encircle with a vessel loop, and then I will try to start dissecting more distally.
Let me interrupt you, since we are only 5 minutes. So the point we were discussing, that how do you prevent an injury to the pancreatic duct, and how do you prevent an injury to an aberrant duct, which you may or may not have seen at the upper end.
Actually, in most of the intrapancreatic part, if you're not sure that where is the pancreatic duct is, we can cut upon the choledochal cyst, and we can localize because we can see the clear pancreatic juice coming from the lower end, and the coning part, we can make an anticipation that this much will go inside the intrapancreatic part. So that will be very helpful, sir, to prevent the main pancreatic duct damage. And if the aberrant duct is there, so I will try to do a doctoplasty, sir, for the common anastomosis. If it is.
Can you briefly tell the students about these 2 important steps? Yeah, Richa, please unmute yourself.
Yeah, so the lower end and the upper end. Choledochal cyst surgery, you can, divide into 4 important steps. One is the circumferential dissection of the cyst, which you have kind of more or less described. Then the lower end dissection, the transection at the right level at the upper end, and then finally the bilioenteric anastomosis. So lower end, after having transected the cyst, when you are dissecting into the pancreas, the protection of the pancreatic duct actually begins with a good preoperative imaging and the ability to visualize the PB junction on a preoperative MRCP. So in a preoperative MRCP, if you have been able to visualize that the PB junction lies distal to the cyst, and there is definitely an abrupt tapering of the CBD proximal to the PB junction, then that gives you a confidence that surgically, very cautiously, carefully, you can dissect the CBD till there is an abrupt tapering. And actually, in whatever number of choledochal cysts that I have operated, my personal experience, the PB junction has always been distal to the cyst. Very rarely it is, into the cyst. So that is one. That try to visualize the PB junction on preoperative imaging using MRCP. Number 2, how aggressive you can be on the intrapancreatic dissection depends, number 1, on the imaging. Number 2, it depends on the quality of the planes. And that decision you have to take on the operating table. So stay right on the cyst wall. The plane of dissection should be right on the cyst wall. Don't stray into the pancreas. And if the quality of planes are good and clean, then while you stay on the cyst wall, gradually, with the help of bipolar cautery, go down till the point where there is an abrupt tapering. However, if the planes are inflamed, very vascular, then sometimes you may need to stop short. Like you have to judiciously balance between leaving behind too large a stump versus being too aggressive and causing a damage to the pancreatic duct. Now, very often in adults or even in older children who have had recurrent cholangitis or recurrent pancreatitis, the intrapancreatic component may be large, and as you're progressing, you may realize that there is a lot of bleeding, inflammation, it is taking time. So then sometimes you either have to do the submucosal dissection for the intrapancreatic part, or you may even be forced to leave behind a disc or a saucer. So sometimes we have needed to leave behind a disc or a saucer. So in the interest of safety, So in that case, whatever residual mucosa is there, that can be cauterized by the spray mode of the cautery, and the lower end is then carefully closed from within. But before you close the lower end, please always irrigate the lower end, because very often there is residual sludge in the common channel, and that residual sludge, if we do not clear at the time of the surgery, will manifest later post-operatively as recurrent pancreatitis. So before you close the lower end, make it a routine practice that you pass a infant feeding tube and irrigate the lower end very well. If you can see a large bulk of calculus in the lower end, sometimes you can even do a and use that intraoperative choledocoscopy for clearing the lower end of all the sludge. So that is what I would say for the lower end. For the upper end, I mean, because as sir very rightly said, you should try to go around circumferentially in the distal part rather than the proximal part. So usually distal to the junction of the cystic duct with the choledochal cyst for several reasons. And to prevent aberrant ductal to prevent injury to an aberrant duct, which we may not have picked up on preoperative imaging, a routine good practice is to actually open the cyst a little distally and inspect from within. So, if there is an aberrant duct, you will be able to visualize an extra orifice from which you can see some bile coming in. So make it a part of routine practice that once you have transected the cyst, open it, inspect from within, and then you progress proximally. So, sir, is that what you wanted me to explain?
Yeah. So if you identify an aberrant right duct opening into the cyst, there are two options. One is that if it is a significant size duct, then you excise the cyst, which will make two openings. One is the common hepatic duct and one is the aberrant duct. And if they are close together, then you do a septoplasty. If they are distant from each other, then you have to do two separate anastomosis. The other option is that you leave a part of the cuff of the cyst which is surrounding this opening of the aberrant duct and use that as a part of the hepatico-jejunostomy. But
another thing, sir, like which we used to discuss on the rounds very often, that in the typical kind of an anatomy wherein you have a cyst and then the proximal CHT is almost nearly normal in diameter, say 4 millimeter, 5 millimeter. So sometimes when we try to excise the entire cyst and we realize that now we are left with the 4 millimeter CHT, which is very thin walled, and you're trying to do the anastomosis and the sutures may cut through. So that is another situation where it might be wise to just leave behind a thin cuff of the cyst, say for 3 to 4 millimeters, which will help you take sutures which will stay. I hope I'm being able to communicate the message across that sometimes the proximal CHT is narrow, it is very thin walled. So in that situation, just leave behind a rim, which will help you take sutures securely.
I think we are 4 minutes beyond, so we will close the session. Thank you, Richa. Thank you very much for joining. Thank you, students who joined the discussion. Thank you very much.
So can I ask a question? One last.
Yes.
Can we do a Whipple's in a giant choledochal cyst? In an adult? No.
There are some reports of Whipple's in a giant choledococele, where the entire choledococele is intrapancreatic. But in a choledochal cyst, as Dr. Richa said, that if you stay close to the cyst and unless there has been recurrent cholangitis or recurrent acute pancreatitis, you will find a plane and you should be able to go down and do a complete or a near complete excision of a choledochal cyst. I'm sure there must be stray case reports where people may have done a Whipple's, but I don't think that is what I would expect you to say in the exam, at least.
And other things, sir, I think, I mean, Sudeep has raised a very valid point, but sir, would you not say that when you're doing a Whipple's in a soft pancreas with an undilated pancreatic duct, that's a huge risk.
Morbidity is very high.
Yeah. When you are, considering that choledochal cyst is essentially a benign disease. So if you're doing a PD on a soft pancreas with undilated,
I don't think that you should probably mention it in the exam.
Yeah.
Yes. So another is a cutoff of diameter CBD in a fusiform pattern you would like to operate. Your institutional practice.
We didn't discuss the forme fruste type. Maybe Richa, you can make a quick comment on forme fruste.
So, the forme fruste essentially is when there is minimal or no biliary dilatation, but there is a very prominent long common channel, and the patient presents with recurrent acute pancreatitis more often, and of course can present with biliary symptoms. So here they say that more than 4 millimeter, but less than 1 centimeter. That is what, the textbook says, that if you have minimal CBD diameter, which may be more than 4 millimeter, but less than 1 centimeters, there is a distinct long common channel. The patient presents with recurrent acute pancreatitis or biliary symptoms. That is what formifraste is about.
More than the diameter, it is the anomalous junction which is important. If there is an anomalous junction and there are symptoms, even if the CBD is not dilated, you take it as a formifraste choledochal cyst, which in a child, in a young adult, in a middle-aged person, you would like to treat.
And your worry is about the ostium size, I guess. That is why you are asking the question. So
Yes,
when you
sir.
have a relatively smaller diameter CBD, you can always spatulate. You can spatulate the end of the CHT so that the anastomosis itself is at least more than 1 centimeter, because eventually this anastomosis will shrink. So you can spatulate it. You can do an anterior ductotomy to make it wide.
Like in biliary stricture, you extend the anastomosis into the left extrahepatic part of the left hepatic duct so that you get a wide stoma even if the duct is not dilated.
Okay. Okay, so thank you, sir. Thank you, ma'am.
We'll close the session. Thank you, Richa. Thank you once again.
Thank you, sir. Thank you.